Okay. Obviously, patient assessment is problem-oriented evaluation. Basically, we want to find the life threats immediately. That's big priority right there. Then after that, once we find the big stuff, we start working our way down the little stuff and we're going to sit there and say, okay, well, why is this happening? Trying to figure out why somebody having a heart attack and their pressure's dropped to about 70 palp and they're sweating bullets and they're about to go unconscious on you. Let's take care of that first before we start figuring out why they're going, they're swirling down like that. Things to talk about: dispatch information, scene size up, mechanism injury, nature of illness, safety considerations, impressions, assessment, etc. Okay, dispatch information. It may provide information especially of what you're going to or what environment you're going to, such as mechanisms, hazards, number of patients, resources required, and so forth. Understand its dispatch information is really dependent on the caller, not the actual dispatcher. So whatever that caller information can give is kind of how they kind of dictate things or how capable they are of giving things, kind of lets you know what's going on. So obviously respond to car versus train with car on fire, multiple victims. That's going to be an interesting day.
Car versus train.
I don't want train versus car.
Tomato, tomato.
I don't think he's going to be much of a patient in that.
I was going to say, might be a sport day.
Yeah.
Might be pretty easy.
Sit back, watch the fire department, get some marshmallows out.
I mean, was the train moving? The car could have just ran into a stationary train. You never know.
We've had some train versus people calls.
Oh, yeah.
How wide wasn't people versus train?
I mean, it was,
Was the train going after the person? Just saying.
It was like obvious, it was like a suicide attempt because the guy that was with him said, yeah, he wanted to kill himself. I guess that's a good way of doing it.
But then he
So
really
he wanted the train, so he was like laid out on the tracks.
Ugh.
That'd be horrible. Like, I think I could jump in front of a train if it was coming, but I couldn't like lay down.
I feel bad for the conductor. Of course,
You can't stop.
Trying to stop all that. I mean, that's just.
Watch it happen because you're not going to stop. You have to just watch it happen.
So it's like,
Yeah.
oh,
I mean, so what do you do? Do you try to hit the brakes or just accelerate to go fast?
You're immune to it.
What do you do exactly?
Cow, human, dog.
Anyway, size up begins with dispatch information. Ideally, it's like, okay, if you're going to call to, somebody who's been shot, you're going to think, okay, well, what am I? Start running to that list of where's this person shot, where could they be shot, what am I going to start doing about it, how am I going to prioritize? That's kind of a way to actually think about anytime you get dispatched to a call. I know it's kind of hard when you're being precepted because you don't hear it over the radio sometimes, but if you do hear it, it's like, okay, if I get called difficulty breathing, what issues can cause difficulty breathing? How am I going to take care of it? What do I need to do? Start to basically just kind of get your mind working so when you come walking in the door, kind of figure out what your plan is going to be and just kind of be able to act on it. When you come up, obviously on the open road here, let's see, what hazards do you see? Big thing is when you're approaching to something like this, again, look for hazards. Always look for hazards. Like kind of saying, always going into a house, look for something odd. Look for somebody with a gun hanging around, because it's very easy to get that tunnel vision. Oh, hey, I'm going to come here and take care of you. You've got all this other stuff going on around you. So again, what hazards do you see? What's the mechanism? Estimate the number of patients. Do you need heavy rescue? Do you need a coroner? It just depends. Really. Something with a lot of patients, sometimes it's best to call, a bus. It's, why, if you got a bunch of about 30 walking wounded, you don't need an ambulance, you need a bus. Take them to the hospital that way. Radio size up, what's involved? Every place is going to be a little bit specific. Or a little bit different and a little bit specific. Some people are going to want you to just sit there and say, hey, on scene, 3 vehicle traffic accident. Send another ambulance. We're going to stand by for patient count. Some people are going to want you to sit there and get on scene, do the patient count, and then call in for what you're doing. So we kind of, when it comes to incident management, we kind of have, a general guideline, but a lot of places will kind of like tweak it to whatever their needs are or whoever's coming and so forth. But the thing is with a radio size up, it's communicating to, one, to dispatch to what it is you have, and 2, it also lets responding units know what they're getting into. Because if I sit there and and this is always fun to do, by the way, and I know you guys will do this. When you're the first unit in and you're trying to do a size up, you're almost kind of like in panic mode because you're trying to figure out, well, I've got this, okay, I've got about 3 cars and they're about this, and you're like, okay, I got to figure out all these 30 things at once. And of course, the responding unit's like, do these guys have any clue what they're doing? Everybody does that too, by the way, just to kind of, I'm sure you guys done that. But when you're the first one there, you're in panic mode at that point. You're like, ah!
That was stupid.
But just to kind of let you know. But ideally, is that whole point of that size up is to sit there and tell whoever's coming, hey, this is what you're in for, or telling dispatch, hey, I've got this, and they may already being proactive and saying, okay, let's start toning out this person, this, and this unit right behind it. So, what's your size up of this incident?
Major damage, standby patient count.
Yeah. Yeah, rollover, possible entrapment.
13 minutes.
Huh?
Wait for the
I'm immune to it. It's no big deal.
So, again, it's this scene assessment here. Who is the patient? It may be more than one. Obviously, if it's more than one, we have to go to the triage thing. Traditional triage, or the ideal triage, is you're the first in, last out, and you shouldn't really be touching patients. I mean, you're just kind of there watching and mitigating. That's really good triage. Let everybody else do the work. And if you're really, really good at triage, everybody comes in, everybody goes out, and you didn't touch anybody.
No transport.
That's a good triage right there. So, again, special resources. Do we need extrication, rescue, hazmat, or just more people? Sometimes you just need more people. So, what really happened, kind of thing. Okay, general impression. What's the mechanism of injury or nature of illness? Big thing here is, like I said, this is all this stuff. Whether you're coming on scene or walking into somebody's door, this is all the stuff you want to start looking for right away. What kind of environment I'm walking into? Does it smell like about 30 cats live in this place? Kind of a deal. Or, have you guys ever gone into like houses where people are hoarders? Mm-hmm. You're like stepping in over and tripping stuff. And I remember actually there was one, they kept saying, it's like, this place it goes on fire. You guys are all dead. I actually got pictures of when it went on fire too.
Right. And they're all crispy in back.
Oh, it was.
Underneath
I think it was just. Well, there was one. I remember they just sat there and said, we just need you to go in and make a pronouncement, and it was about. God, I remember I was going through about a room. It was about this size, and had to go back through a back door, and it was stuff literally piled up to the ceiling, papers and junk, and we were walking all over and around it. And you walked in the door. You could smell this guy was dead. But we're just walking around. I was like, yep, he's dead. But he had all this stuff just piled. So, but general appearance and behavior. Again, this is just one of those things of do this with everybody. Anytime you get around any kind of sick patient or any patient, start looking at their appearance and say, is this normal? And if it's not normal, what's not normal about it? And then start putting the names behind it. Maybe they're lethargic, maybe they're acting agitated, maybe they're saying, nervous, maybe they're anxious, however you want to do it. Because eventually, after a while, it becomes second nature. You don't even think about it. You're like, oh, okay, I see what you're doing. You're sick. I don't have to worry, think about it. But right now, for the learning process, think about those things. It's like, does this person look sick? They're not sick? If so, what kind of degree of sick at this point? Are they talking to me? Are they not talking to me? Are they trying to make sense? Do they not make sense? And so forth. The other thing is obviously is going in the obvious injuries and illnesses. If you come in and there's throwing up all over the place, that's kind of a given, at that point. But patient activity and awareness, again, this is just going to tell how well they're mentating. If they're throwing up all over the place and they kind of lift their head up and they can barely say a couple words, I'd be kind of concerned at that point. They should be able to talk to me. Even if they are, retching. If they're not, how much have they been retching at that point? And that goes like with any sick patient. How mentally aware? Because if not, something is not making its way up here. I got to figure out what that deficit is. Ooh, what's this?
Well, they use your power line, didn't they?
Mm-hmm. Yeah. Those are always fun ones to go on to. Because you pull up, you see the power line there, you sit there, and you're like, aren't you going to come help me? Nope. Wait for the, we're waiting for the electric company to come by. Why? That line right there? So little things like that, You see little power lines, you'll just be like, nope, won't even come near it. So this is kind of this might require some paperwork. I don't know if I got the picture of the medic who decided to go through the compact side of the tollway from Austin. Blew off the sides almost clean off. I think I got it somewhere. I don't think I'll dig it up. It was impressive. Again, somebody getting overzealous, not kind of thinking it's like, wait a minute, just because it's an emergency doesn't mean you get to kill yourself on the way there. But yeah, just rip the sides off. It was pretty cool. So safety, what types of safety hazards might you encounter in these situations? How might you minimize your risk? How about, yeah, that's a little bit of a crunch.
And the car. You're on the highway.
I actually saw something like this happen some odd years ago. And it was pretty much, we got there, and what happened was this, like a little, I think it was a Jaguar, got under a semi, then got ripped out and tumbled kind of a thing. So when we got there, she was, say head injury was the least, at the very least. Anyway, we found out later what happened was she was on her cell phone talking to her husband, and she's like, yeah, I remember talking to my wife, and all of a sudden they heard bump, 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 bump in the background. It was that quick. So, but yeah, that was So anyway, going back to what we're doing. How might you, violent acts, domestics, a good cutting. How are you going to minimize your risk to injury and illness?
To myself, I'm going to save. Is that what you're talking about?
Yeah. Stage. What if you're walking in there and you see somebody sharpening their knives?
Walk back out.
Yeah. So yeah, police are really good for those kind of things. They get paid to get, as far as I'm concerned, they get paid to get stabbed and shot, not me. Okay, what about a motor vehicle?
Make sure it's in the park, brakes are set, no fluids leaking.
Well, you can't stop the fluids.
Well,
Well,
I guess wait till hazmat or fire gets there.
What else?
Down power lines if they hit a power pole.
Anything else?
Can you block traffic?
That right there is a big one. Those guys will, some of those guys will keep going right there. And I remember one time I was outside. I remember having my flashlight sticking out like this. And I remember this guy zipped by and hit the flashlight. I about jumped. It's just like the most nerve-wracking things because, it was his little side rearview mirror that hit my flashlight.
Use the flashlight and throw that over.
Yeah, that was creepy. That was creepy. Yeah. Now you got to really. Sometimes the passerbys are the worst. Sometimes they call them rubberneckers. Kind of a thing. So those guys, like I said, some of them will slow down and kind of see what you're doing, and some people they just like, screw it, ain't my problem, and keep going by. Ill person in a building.
What caused it? Is it a biohazard or?
Yeah, what's the building, right?
It's environmental.
Yeah, we'll build an office building.
It's an office building. Is there more than one person still in the building, or?
Let's say it's one person.
Where are they located? Where are they standing by? Right over the AC vent that's blowing out some kind of toxic gas.
Actually, what if they were standing over the AC vent? We're trying to huddle next to it.
I mean, were they hot?
Yeah,
Were they really
Yeah,
hot?
how hot are they? How hot are they that they're hugging next to an AC vent and they're sick? So it's little stuff like that. It's kind of like, you got to start developing, why are you doing this? Why are you acting this way kind of thing? So sick or not sick? Kind of a classic term, but does this patient look sick or do they not look sick? You're going to see patients who say they're sick, but they do not look sick. And like I said, when we're looking at sick is, like I said, do you look like you're pale? Do you look like you're sweating bullets? Do you,
Look like crap.
yeah, LLS is the other one.
Not crap.
Huh? LLS?
Yeah,
Yeah.
not crap, but
Yeah. You just, that one extra step. So, and like I said, at that point there, it's kind of like, is there potentially a life-threatening, condition? Obviously, it's a life-threatening condition. What do we need to do about it quickly? How are we going to do about it? Or if they're looking pretty sick, how far are they for becoming really, really sick? So, that's just, again, take advantage of all the time, especially in the ER and whatnot, in ICU and stuff, to start seeing what really, really sick people look like. What their skin looks like, what their skin feels like, what their pulses feel like, what their respiratory rate looks like just coming off, when you just gauge them coming in the door. That's going to help you. Then versus, you see someone coming in, it's like, yeah, I've been sick, I've been throwing up the last couple days, and you're looking like, okay, wait a minute, you're talking good, your color's good, you're standing upright, you're using hand gestures, which is good, obviously. You got some circulation there, you're tracking, you're looking around. You're sick, but you're not sick. Versus you're coming in, you're like, look like you need to be buried, kind of a thing. So assessment, obviously we're going to go ABCs. Unless there is a potential for spinal injury, then at that point, the thing is, if we think there's a spinal injury, let's just get C-spine now. And if we can talk to the patient, they're oriented, and we can rule out a spinal injury, hey, that's fine, but at least we covered it. And otherwise, if it's a traumatic injury, we'll just kind of go, cervical immobilization, kind of work our way there. But again, it's a simple stuff here. This, airway breathing, circulation. This is going to tell you more information right off the get-go of where this call is going to go, what direction it'll be, than trying to come in and say, hey, what's going on, what's that and the other. Okay, this is actually something I've really, when I go over there with those guys, I'll bet you I'll throw a lot of those guys off because of that. They won't check that. They get in the habit of, I'm not really looking for it. I'm just going to kind of find out what your problem is. And I actually did it to one group. I remember I would sit there and have the heart rate set at like 30. And like, yeah, and the guy's laying down. He's like, you talking to me? Yeah, he's talking to you. This color look good? Yeah, it looks okay. And they're sitting there talking and talking and talking. I'm looking, because I can look at the clock, and it's like 5-10 minutes and all this stuff. And then, like, put them on the EKG. You have a heart rate of 30. All of a sudden, the lights goes on. Wait a minute, this is a problem. There was 10 minutes that we could have gotten taken care of that, or that 10 minutes, things could have progressed. So always be on top of just on those ABC things. I mean, it will dictate so much so quickly and where things are going to go. Because it's like, hey, at least I know if I can, I know you're talking to me, you're breathing good, you're not obstructed, and you've got a good strong pulse. I know I've got some time. We can start kind of moving around. Then we just then I have to rely on what are your symptoms at that point. But if I blow that off, like I said, if I blow that off now, when am I going to get back to that? So again, circulation, central peripheral pulse, amplitude, irregularity, estimate, identify causes, skin temperature, moisture, color, obviously severe hemorrhage, control it, disability, mental status, what is their mental status, their level of consciousness, or is there a loss of consciousness at that point? If so, why? Posture, what's posturing?
Are they sitting straight up, or are they slunched over tripoding?
That's one way. What else can posturing be?
You don't know, like when they hit like a head injury or something, and they're all like,
Stroke. Yeah. You guys remember what this is called? The corticate? Is this one? The cerebrit? Yeah. The other way we're taught to remember is like the corticate. Remember, it's holding your core. It's trying to hold your soul in, and at this point, you're an angel. Which usually, if you get to that point, you're kind of done. So obviously, obvious sensory or motor deficits. It's like if you got somebody who got a car accident, and they're like, you're sitting there poking and prodding on their open wound injury on their leg, and they're like, why are you doing this? Why aren't you getting me out? That should be kind of a clue something really bad just happened. So, and obviously the other one, defibrillation, cardiac arrest, hunt for VFib. That's kind of one of the things we always kind of look for is, unconscious, unresponsive. If we don't have a pulse, let's get them on and see if we can blast them with electricity right away. Exposure, remove clothing as needed. Prevent overexposure to the environment. The only time I could tell you this, the only time I've ever really seen that really take off most clothes is just in a trauma patient. Most of the time it's just like look up their shirt. Yeah. Or just might have to get the shirt off, so maybe I'm doing EKG leads or something, or that kind of a thing, or cardiac arrest, for example. Determine priority treatment. Threatening problems goes immediately, load and goes, or slightly delays. You know, if they got to go, send them. Go, scram, take off. You know, don't worry about it. You know, it's kind of that the other acronym or little saying is, you know, package pretty, deliver dead. You know, they are sick, they need to go, start going. Direct baseline vital signs. Ideally, sometimes you may be able to get 2 sets, sometimes maybe not, depending on where you are. Ideally, we want to, but understand we want to get a full set of vital signs. Again, is going to kind of give us a picture of, you know, what is their cardiopulmonary or your cardiac. What's the word I'm looking for? They had the term they used in we had talked about last Tuesday. No, it's. I'll get back to it. You guys know what I'm talking about? The vital signs lets me know how proficient, you know, by cardiopulmonary circulation is, you know, oh, that's working at that point. I can't remember the name. So, branching points. Again, this is kind of one of those right tool, right job kind of things. Obviously, if it's rapid trauma, do rapid trauma. You know, if it's something you can do detailed, first check your ABCs and then do your detailed. Last thing you want to do is, you know, find somebody, you know, maybe he's about 45 years old, actually looks like in good health, slipped and he's got complaining of an ankle injury, but the reason he slipped and fell is because his heart rate went to 6 sinus syndrome and he had about a pause about this long where his heart didn't beat and you weren't looking for it. That's where that ABC stuff comes in. Okay, that's where you want to kind of do that. Or, you know, maybe he just had like a run of fib or VTAC or something, and that's what dropped him. Or that's the stuff you got to kind of look out that kind of sneaks up on you.
Not just, hey, what's wrong with your ankle? Like,
yeah.
What caused the fall?
Right. You know, it might have been a slip, might have been a fall, maybe, you know, it's hard to say, but make sure you get that ABC stuff out of the way. Then if you need to go detail and it's like, yeah, it's just an ankle injury, hey, great. Follow it up with a focus. I'd always encourage it. Always follow it up with a focus. You'd be surprised just because, like I said, your mind is only going to take in what is the most painful at that time. You fall and maybe you hurt your back, you've got a little soft spot in your back or something, you don't want to be the person that blew it off, right? So check those things. Just always follow it up. Okay, the rapid trauma, again, identify whether the patient needs to be transported now and why. You know, a lot of times with trauma, a lot of places actually have pretty strict criteria. And saying, oh yeah, if they have 2 long bone fractures or, you know, immunocompromised in, you know, in a motor vehicle collision over such and such speed or something like that. It's usually trauma is pretty cut and dry. That's a nice thing about trauma. So, but anything like I said, it's rapid head to toe. And again, like I said, the thing about head to toe, by the way, I see a lot of people still start here and they'll branch out to the arms.
Yeah, forget about that.
Yeah. This stuff is all that's important first, and then we can start worrying about extremities. But this through here. So just kind of keep that in mind as you're going down through there. And again, we talked a lot about looking at things at, you know, head, chest, and extremities and whatnot. But like I said, if you're not looking for it, you're not going to find it. So what are examples of patients with high priority requiring immediate transport? What's some examples? Yeah, cardiac arrest one. The big one, yeah.
Penetrating trauma?
Huh?
Penetrating trauma?
Depends what kind of penetrating.
Abdominal.
Yeah, airway.
Anaphylaxis.
Actually a problem.
The decreased cardiac output.
Yeah. Septic. People have gone septic shock, neural shock, any of the shocks. You know, they seem to go profoundly shock on some kind of profound shock on you. Head injury. Yeah. Over 20% burns. Or 10% over 55, less than 5 is the other one.
Maybe they got like bit by something.
Yeah, that's what they got bit by.
Snake spider, something like that, so.
Yeah. How many hospitals in the area? I mean, do you guys know that carry antivenom?
Yeah.
The Scott and White?
Yeah.
Yeah, I know BRAC does. That's the only 2 places I know in this area. So.
At that point, like, would you just transport them anyways and just, if they have to fly them out, they fly, like if we didn't, like if the hospital you took them to, they just fly them out?
Probably. I mean, it's hard to say. The problem is most snake bites tend to be dry bites. You just don't know which ones are.
Yeah.
you know.
And that sucks. Because the patient doesn't know. You don't know.
Yeah, until they start saying, yeah, I've got this really weird metallic taste in my mouth. Like, uh-oh, that could be bad. Or I got bit by this little red and yellow snake.
Yeah.
Didn't bite really hard.
Kind of like chewed a little bit.
Yeah. So, I like how you went reverse. So what determines the need of detailed versus focused? I think we kind of, anybody got any questions on that?
Focus is more like, to me, that would be like, if you're having chest pain, I want to kind of centralize to the abdominal area and detail is more kind of after the fact, abdominal.
Well, detail, I mean, I think it's the only time you like do detailed firsthand is somebody's like just unconscious. You know, altered, you just don't know. You know, they're not giving you a specific complaint. Now, if they're giving you a specific complaint, ABCs are intact, we can go detailed. If they're not doing that, we got to just go all over, you know, right off the get-go. You know, then we can, you know, and like I said, if it's detailed, we'll just follow up with a, you know, full detailed exam afterwards. Preparation for immediate transport. Obviously, you know, backboard seat collar, 10-point straps, mask pants, splints, if appropriate, cover, protect, warm. You'll run into this. I mean, I don't really know if they really ever did any studies on this, but they always sit there and try to say, always put a warm blanket on somebody you think you might be in shock. But honestly, a lot of times we're, you know, I don't know about you guys, but a lot of times we're never really too concerned about it because one, we're too close to a hospital at some point, or usually the temperature is not that bad. So that's just one of those little things. Kind of keep an eye out if they ever got through that, you know, getting those trauma situations, or they start going trauma practical. Say, well, I'll definitely put a blanket on them just to keep them from shock. But my also thought is, well, if they're trauma and I've cut all their clothes off, and I'm exposing, looking for injuries, and I'm going to have to reassess. Well, just one of the things if you want to, you know, just play. I'll let you play with that concept for a while. So secure all if you know, helipad transport, helicopter transport. Usually, a lot of times it's the fire departments that are usually will set up like an LZ for you, and then, you know, helicopter comes down, and usually they'll just meet you at your ambulance, and they'll transfer from your stuff to their stuff. But if one thing you'll notice, they're going to come in and they're going to do their entire assessment like you would, even though you've done it. You know, and like I said, that's just redundancy. Because, I mean, actually the thing is, as soon as they get in the helicopter, they're not going to be able to hear anything, or they're going to have very limited access of what they can, you know, get to and feel to. So reassess. You know, just get in the habit. If it's critical, every 5 minutes, reassess. If they're 15 minutes, reassess. You know, vital signs included. Just do everything all over again. Do it. Look for changes. Look for trends. You know, you don't want them to sneak up on you. Sample history. You guys are pretty familiar with sample, right? So, other things you want to look for is current medications, over-the-counter medications, herbal remedies. Herbal remedies can be, you know, some herbal remedies are pretty good. Some of them are just, like I said, there's technically no regulation to them. I mean, if you go to like HEB, I mean, a lot of those people don't want to, will put something a little bit more care into their product, but I mean, you really could put some kind of weed with dirt and market it as an herbal remedy. There's no FDA, nothing to it. So look for risk factors for disease, you know, age, family, you know, genetic dispositions, what sex they might be, family history, alcohol, substance abuse. I mean, that's, you know, alcohol and substance abuse over time is just a lot of wear and tear in your body. Your body is not designed to take all that. Immunizations, especially obviously with kids, occupation and environmental factors, you know, depending on what where we're doing. Obviously, like with us, you're going to be outside in all types of weather. So, in all types of environments, and generally not very safe ones. The other thing I want to jump onto is, I think you guys know OPQ or ST by now. I'm just going to go to the last part here. Associated symptoms, positive or negative. Like I said, talk about the pertinent positives, pertinent negatives. You guys familiar with that term? Yes, no? Pertinent positives is, okay, you have chest pain. Okay, is it radiating anywhere? Yes, okay, there's a pertinent positive anywhere. Okay, do you have pain in your teeth? That'd be another pertinent positive. Versus, like I said, if you have chest pain, you know, is it radiating into your left arm? You say no. Now it becomes a pertinent negative. If you have it to your teeth, and say no, it becomes a pertinent negative. That's how you, so it kind of helps reinforce and build what your direction you're going to, or it takes away and say, okay, maybe it's not really that. And those are things actually you need to be able to document as well. You know, you don't want to sit there and say, yeah, patient had chest pain and went and dropped a bunch of nitro, and you turned out with some kind of like pneumonia thing, and they already had a pressure of like 80, and you know, you're about 3 nitros into this, and you're wondering why they're dead. You know, I guess it was a really bad heart attack. It just killed them. So, getting history is like charting a map. It's also like solving a puzzle. You know, yes, you may be very clear it's chest pain, it's cardiac chest pain, but you definitely want to make sure it's not pulmonary or any kind of musculoskeletal pain. You know, or a chondritis is an example of good chest pain that can pop up. Inflammation of it's actually inflammation around the sternum here where it meets. That can give the same thing. So, and again, looking for data supporting to what you're doing, or at least taking away, and making sure that one disease process, you may find chest pain, make sure it's not affecting any other adjacent systems. You know, you have circulatory issues or pulmonary issues coming with it. You know, I have chest pain, I've got chest pain and having problems breathing. You think, oh yeah, because you're having a heart attack and you forgot that their lungs were filling up. So, other little toys we've kind of talked about before: glucose, pulse ox, EKG, strokes, so forth. And you guys are going to remember how to remember your cranial nerves and how to assess for them, right? So anyway, develop a plan. A lot of times it's really developing, it's kind of almost developing your own little way of your own little diagram, your own little tree diagram, if you want to put it, your own little algorithm. Find a system that works for you. You know, I mean, obviously a lot of times I'll tell, a lot of people are relatively new, like looking at those national registry sheets, especially between trauma and medical, are good guidelines to start. Build off those so it can take you whatever direction you need to. And just learning how to be able to flip from one direction to the next and backwards and forwards. So, but, develop a plan with the diagnoses. I mean, obviously the appropriate therapies that go with it. Always plan for the worst. I can always emphasize that, always plan for the worst. So, and always stay a couple steps ahead. Just because it's like, yeah, like I've seen, like one thing I was running into for a while, it seemed like my asthma patients, they'd either bounce back from albuterol, or they just wouldn't at all. And it seems like if they didn't bounce back immediately from that albuterol, I was like, okay, well, what's going to happen next? It's like, oh yeah, I give another albuterol and Atrovent, but it seemed like if that doesn't work, what's my next plan? How bad is bad going to get? And sometimes you're just kind of like putting out, the intubation equipment, or just, let's just keep this right here if something happens.
What are you doing? Oh, nothing, just in case.
Oh, they're not even paying attention. No, they don't pay attention until you pull out that.
It's like you're like, okay, it works.
No, you're doing this.
Right tight.
You're doing that. They'll notice that. So consult the doc if needed. I mean, that's what they're there for. That's what they get paid the big bucks. Give them a call. I mean, if you sit there and you've gone through everything backwards and forwards and you're not clueless, or if you're clueless, call them up. I mean, I could think of one situation. It was probably about a year ago. It was just like I couldn't decide if it was a stroke or an MI or both. And I called them. I was like, look, I think I've got both of these going on. I can't decipher which another, so I'm going to call and let you know this is what I'm coming with. Okay. It happens. So, and transport appropriately. If you need to go licensed sirens, go licensed sirens. If you don't have to, don't. Remember, just licensed sirens actually kind of puts you more of you at a risk than anyone else. People freak out when they see licensed sirens. And the thing is, like I said, if you are driving licensed sirens, just remember, take your time. Don't kill yourself over somebody else. Don't kill your partner back there because you need to freak out and I got to get to the hospital quick. Dead injured rescuers do not help anybody. All right, let's take like 10 minutes, and then we'll head that way.